make the mood lighter on that. So starting on that note, we'll talk about technique, we'll talk about X-rays, different views, and let's see how the babies play game with us. So essentially in technique, the radio, or all this X-rays is simply nothing but the high magnitude and with high velocity traveling electrons. So these are short electromagnetic radiations. They are produced by energy conversion, and when the fast moving electron, they move from negative to positive side, from cathode to anode, that what we used to study in our physics. Okay, they hit the target, and from target it scatters, and the filament which creates an this flux of electrons, they hit the target. Target is on the anode side, the positive side. From the scatter happens, and the scatter is diverted to a specific areas which is exposed to radiation, and those what we call an X-ray, and we'll see how the X-rays are being produced. So when his X-ray beam is directed toward a specific part of the body, the part either absorbs or rejects the whole radiation. So X-ray absorbed by the tissue according to density caused by ionization in the body. So how much ionization radiation can cause, and according to density, the view changes. So black areas represent region they have allowed the whole X-rays to pass. So that all the areas which don't let the X-ray to pass, the solid areas will look more brighter to you. The areas which will let everything to pass will look black to you. So overall white areas represent region they have absorbed all the X-rays. So nothing has gone to the plate. So those are the sort of voids. But voids, on a very different way, it is being shown as white. And where the X-rays gone and reached the plate, those are the gains. The gains are shown as black. So then what they do? They do an uncoupling. Uncoupling essentially means they separate out the areas depending upon how much the radiation they're exposed from the plate. So where the final product is uncoupled from the amount of radiation utilized. So essentially means the plate is being read in a way that what areas have utilized what kind of what kind of radiation reached there. The maximum amount of radiation which has reached, which will look black, and where the none has reached, that will look white. So that's called an uncoupling effect from the whatever radiation is given and whatever radiation has been detected by the plate. They uncouple both, and the image is being created. So if we see this, patient dose is calculated microsievert unit, and in overall an adult, when they taken chest X-ray, approximately 60 microsievert they're being exposed to. And as per the weight, as the weight advances, okay, the whatever maximum kilovolt or peak kilovolt what we use, that keeps changing. The smaller the baby, larger the radiation magnitude is used, but maximum what we see, they are scattered around between 2.5 to 3 kg. These are the babies who are maximally exposed to radiation. And if the density of radiation, okay, that is almost plenty of time, it is as good as an adult X-ray, or sometimes even majority time it is the half of it. So this is what the radiation is exposed. What does it mean? We'll see that in subsequent slides. So when you decide in exposure, so exposure is either in terms of peak kilovoltage and the milliamperes for essentially the AP radiograph or neonate. So as you see on the left side in this chart, as the weight increases, the peak kilovolt, they keep increasing a little bit, but overall the milliamperes stay the same. So this is what you set on an X-ray machine, that how much exposure do you want. Generally milliamperes are generally pre-decided on the kind of capacity of machine you take. It is either 0.51 or 2. So generally adults one which has where you need more penetration, generally those are the maximum which goes up to 2. Sometimes it can, the machine available which can go up to 5 also. But these are generally not in commonly used. This is generally what simple neonatal machines, what we all must be having in our own units. So this is what they have preset. Yes, there's a way to increase it also, but this is what you set on the panel. So this is what is being set. So overall, if you want to sort of try to do an X-ray on your own without help of a technician, this is the kind of numbers you should remember. If you want to take a snap of this slide is perfectly fine, or if you want, I can share the PDF also through NeoChap to all the participants. That kind of, if you want to take a chest X-ray supine, okay, you set approximately in 0 to 6 months, maybe approximately 60 to 65 of peak kilovoltage, approximately 1.5 of milliamperes, and that if you want to do lateral X-ray, a little more because the bony density comes in between, and so on and so forth. So overall, the important prerequisite is that the baby should be carefully positioned, because if you don't position the baby carefully, the first and important thing what happens is that baby is getting exposed to another episode of radiation. Ye to X-ray theek se nahi aaya. Let's do another one. Okay, so there is no end to it. And second thing, you avoid artifact which are produced by rotation. We'll see how the rotation affects the X-ray. And simultaneously to avoid the erroneous diagnosis of cardiomegaly and a mediastinal shift. So if the baby is rotated, if the heart comes closer to the X-ray beam, okay, you will see that the heart is unusually enlarged, and you sometimes feel that the mediastinum has shifted. And simultaneously, many of you must be knowing, but the area which are nearer to the plate will look more brighter to you. The area which are away from the plate will look more darker to you. So if the baby is rotated, for example, baby's right chest is in front and the left has gone back, you might misdiagnose the left hemithorax having pneumonia because that will look more denser to you. Or you might diagnose pneumothorax on the right side just because it will look more darker to you. Okay, so because of difference in the translucency changes in different both hemithoraces, you might misdiagnose either as some pathology or sometimes an air leak. Simultaneously, we want to precise interpretation of the position of lines and catheters. Okay, again, the position of the baby is very, very important. The most common radiograph what we take is supine AP X-ray. We don't take PA, we don't otherwise take lateral ductitis or any other X-rays unless there are specific indications for it. Overall, arm should be extended above so that we prevent we can spread sideways so that the scapula are not obscuring the lung pathology. The beam should be centered at nipple line. We'll see how it happens, and the radiation area can be collimated to the outer chest margin. With digital system, a radiographer is able to apply electrical shutters. So, for example, if the radiographer is exposed the baby completely, rather than taking just a check size, he is taken invertogram. While developing it, he has a capacity to apply electrical shutters, where he will expose only those areas or process those areas only which has been asked to, even though the whole baby is exposed. So you need to be after the technician that what areas to expose, because this once they have this capacity to do it and during processing. So this conceals a poor collimation technique, that unnecessarily leads to almost always leads to more radiation exposure to the baby. We'll see what this collimation is. So for example, I want to take an X-ray of this baby. Okay, so first of all, the hand should be spread wide apart. Anything which has something like buttons or anything kind of things on it, okay, should be opened. Okay, otherwise the cloth need not to be opened. Okay, we'll open it just to see the technique. Okay, arm should be spread on the sideways or maybe above, if it is possible. Baby should be centered nicely. Okay, because plenty of time, because of this bed what we make in this well, babies can tilt a little bit here and there. So see to it that the baby is not tilted to either side. This is how the X-ray beam from where it comes, the window looks like. So this has this horizontal and vertical lines which will get projected on the baby's chest whenever we are centralizing or when we are positioning it. See to it that this X-ray unit, okay, it is not oblique or it is in sync with the tilt of the bed. So for example, the bed is tilted to around 15 or 30 degrees. This also should be tilted to 15 or 30 degrees. If you can't do it, then it's better to keep the bed flat during the time of X-ray. Okay, if you are not so sure how to do it, or if you are relying a lot many time on just a technician and the on-duty nursing staff who may not know how to exactly match the angles. So when you turn on the beam, okay, this is the kind of lines you will see. So the horizontal line should come at the level of nipple. This vertical line will come. And can you see where these lines end? More or less not. Okay, that means the scatter is too huge. So then there are shutters available. If you see the previous one, there are few buttons on either side, okay, which can limit the amount of radiation exposure from both the sides. So they can limit the amount of exposure from up and down or from the side to side, to see to it that the radiation, that field comes just to the outer margin of the chest. If you don't want to take the abdomen, then just expose the upper 1/3. If you want to take the neck, perfectly fine. If you don't want to take, then upper margin should stay somewhere and where the neck starts, because you would like to see the pathology in the spine also. So from where the neck starts till the upper 1/3 for the chest X-ray. If you want to take an abdomen X-ray, include the pelvis, and simultaneously you can just expose the lower chest, may not expose the upper mediastinum also at that time. So this is how the collimation and the scintillation happens, and then you click. So overall, good quality radiograph should not be rotated. We'll see how the rotation looks like. It should extend from lung apices to at least T212 to L1, that is just an upper 1/3 of the abdomen. If the position of the umbilical catheter or arterial catheter you want to look at, then maybe X-ray should cover the upper 2/3 of the abdomen. See to it that you don't handle the baby excessively, or you time the X-ray according to whenever they are getting handled. So if you handle a sick neonate, it can lead to episodes of bradycardia and hypoxia. And if you see the episodes of bradycardia and hypoxia, the 75% of the time it is related to some or the other type of handling. So please, X-ray should not be one of them. And yes, now almost even the cheapest open care do have this kind of under tray. And they have a marking on the other side. So see to it that you put the tray in it. Okay, see if it is being properly placed or not, and then take an X-ray so that you need not to handle the baby or put the baby, lift the baby up, put the plate beneath the baby, make the baby lie on the plate, and then take an X-ray. So don't do this kind of handling. Rather use an under tray. These are a few type of X-rays we'll look at. This is something called cross-table supine X-ray, in which the baby lies supine. Okay, the plate should lie towards the area of interest, and the beam should come from the opposite side. Okay, the X-ray more or less looks like this, where you can see the spine, you can see the mediastinum, you can see the airway, the chest, and the sternum, and maybe the ribs in between. So this is how an X-ray looks like. We'll see when we see the other plethora of X-rays, how they look when we take the cross-table lateral X-ray. If you have any questions, please start noting down in chat box, and I'll try to answer them as in best of my capacities at the end of the lecture. So this is how we take cross-table supine X-ray. Again, the baby is lying supine. Okay, C2 baby lies flat on the table. Okay, hands are drawn up so that the scapula and the hands don't cover the chest exposure. If I want to see the pathology on the left side, my plate should stay on the left side. If I want to see pathology on the right side, I'll put the plate on the right side, and the beam will come the opposite side. Here, look at this scintillation markings, and yes, you can collimate according to the area what you need exposure to. These are the shutters I was talking to you about, which are horizontal and vertically. They can reduce the field of exposure of radiation, and you should see that they are approximately placed according to the need of the exposure. Another view is CTAPL view, that is called cross table prone lateral. So cross table is across the table. We keep the baby prone and we take a lateral X-ray. Same as how we have taken the cross table supine X-ray, but this is the prone. Mainly it is being done for anorectal malformations. So you can hold the baby down, or you can even make the baby supported with linen, and you can give this position to the baby. It is popularly also called as the position of sajda. If you've seen the Muslims praying namaz, okay, the sajda position is the position. If you want to remember it, the CTPL view. When you take an X-ray, generally it is only for anorectal malformation. So a marker is being placed where the sort of would be NS, generally it is mainly for anal atresia or imperforate NS. So where the NS should have been, so where the marker is being placed. So this is the kind of X-ray it is going to show. So this is the marker has been kept. So where the NS would have been thrown X-ray, and you should see the kind of a blind end of the loop of the intestine. For the blind limb loop to come above, okay, at least keep the baby in this position for 2 to 3 minutes before you do an X-ray, so that the intestine have a time to move and you don't diagnose unnecessarily a low ARM with high RM. So this is a kind of another example how this sajda position looks like. This is the marker. We have just put an ECG lead here. So the button looks like this. This is where the blind end of the intestine is, and the distance is measured, and the surgeon takes a call accordingly. So this is how you take a cross-table X-ray. Talking something about radiation exposure, because we are very well versed with X-rays that we sometimes don't see the hazard. You know, it's like looking at a best friend, but we don't see its shortcomings because it's our best friend. So X-rays have saved our lives, saved our ass so many times that we don't see what the radiation exposure does. So overall, these the exposure effects are generally divided into 3 parts. One thing is we call deterministic effect, where you see that, for example, if I want to create a cataract in a lens, so this much amount of radiation exposure will create cataract in the lens. So that's a deterministic effect. It is unethical to do such kind of a testing. So these are the mainly data which have come from the survivors or maybe the people who have died during that time, during the Hiroshima Nagasaki bomb exposure. So because of that radiation, okay, those are the deterministic effects. Still, we don't know because nobody can does a trial. You know, let's have some amount of some human subjects and put an radiation there and see in how much radiation the cataract forms. And nobody can do that kind of a trial. The most commonly other effect is stochastic effect. The stochastic effect are nothing but because of repeated radiation exposure, they're insidious in nature. And the basic principle is that any radiation may cause DNA damage because it depends upon what portion of DNA is injured and how the DNA is placed. If the DNA is rapidly multiplying, then it creates more of a problem. So since the effect occurs at random, the probability of DNA injury is at any dose. Okay, so if somebody tells you, okay, no, this much amount of radiation is fine with me, or it is safe for you, don't believe any of this bullshit, because effect occurs at random and there is high probability of DNA injury at even low doses of radiation exposure. So there are no safe threshold. And hence there is a concept of linear no threshold, that no level of radiation exposure can be assumed to be absolutely safe. Because if you see that every day, each of us receives approximately 1 millirad of radiation from environmental sources, rather from environment, from sky or from the core of the earth. The unit of absorbed dose is mentioned as gray, and the unit of absorbed dose which is equivalent to our effective dose, which can cause radiation exposure, radiation damage, or radiation protection, that is calculated as sievert unit. So overall current doses, they overlap those doses from which excessive cancer have occurred in the atomic bomb survivors. As I told you, many of this data of this exposure and their effect, it has come from the era from the Hiroshima Nagasaki exposure, and mainly a derivative of those. Okay, and there is no point in doubting that data, because yes, we know that universally the radiation is bad. So if you see the radiation exposure, the effect of radiation is greatest on the faster growing organisms. So something like fetus, infant, and young children, and same which are glands which are rapidly multiplying or rapidly undergoing some turnovers, like thyroid gland, breast tissue, gonads. They have higher sensitivity in growing children. And gradually, as we talked about in stochastic effect, the lifelong cumulative effect of radiation keeps piling up. It adds to children's vulnerability to radiation carcinogenesis. So we never know that the whatever radiation we have given to a newborn in our neonatal period may lead to their vulnerability to develop cancer maybe later on in their life. Younger the patient, more time they're exposed to radiation, there are higher the probability. Okay, what's the linear equation? What are the numbers needed for it? Nobody knows. So if we see that the background radiation was approximately 1 millirad per day, approximately comes to around 300 millirad a year. Imagine what we do when we take an X-ray or do something. So if a baby undergoes a chest examination, maybe around 2 views, okay, or 2 X-rays, so we are exposing them to around 10 to 20 millirad at that time. If we do one abdomen X-ray, we expose them to approximately 50 to 100 millirad. So approximately around 2 months dose we have already given in one go. Same way, if we subject a newborn to a CT scan brain, then it exposes the child to approximately, in adult, approximately 6 rad, and in children, approximately 2 to 3 rads. So that comes to around 3 divided by 300. Okay, milli is in, oh no, that was 1,000. So approximately we have given the radiation expert for the whole life to this baby, even from the, we have covered couple of next genomes also. So if the baby has, we expect them to have 7 janam. Okay, 4 janam ka radiation exposure is just with one CT head. If we do CT abdomen, again the same exposure for 3 rads in the adult and approximately 1 rad in baby. So approximately a 3 years dose has been given to that baby. So thus this kind of scan dose is expressed as CT dose index. So here the first dose which is mentioned is an adult dose, and this is the pediatric dose in dose adjusted for children. So overall, see to it that the simple radiation, as simple as X-ray, is not so safe, and so try not to do an X-ray when it is not indicated. So these are indications for not doing a chest X-ray: is daily in ventilated babies, as a routine in pre and post extubation. After each reintubation to confirm ET position, there are so many papers now about the POCUS. There are so many clinical methods that have been identified to confirm ET position and whether the ET tip is at the right place or not. And more or less as a knee-jerk reaction to every SpO2 or FI2 change. Okay, that's when, when you're in the middle of the night, sleeping, your junior doctor, staff nurse or resident calls you and tells you that this baby seems a little tachypnic, and otherwise ventilation going good, but the FI2 I need to increase from 30 to 35. Okay, so first is X-ray कर मैं आके देखता हूँ या blood gas कर मैं आके देखता हूँ. So please don't do it as a knee-jerk reaction to every SpO2 and FI2 change. Try to take a more clinical decision and do it only if needed. So how a normal neonatal chest looks like? So generally newborns, they lack normal low doses, what we see in older children. So that's why the newborn chests are more straighter. So sometimes you might see the clavicle may be projecting above the first rib, which may not be there in the adult or the in older children's X-ray. Diaphragm should be dome shaped. The level should be at the 6th rib anteriorly and 8th rib posteriorly. So that is mainly if you are doing a lateral decubitus X-ray. CT ratio is approximately should be less than 60%, but that's very variable. We'll see how the CT ratio is also calculated. And the classic epidothymus is a wavy outer border, and maybe it look like a sail of a ship, and hence it is called a sail sign. We'll see the X-ray also have a sail sign. Looks like, so more or less this is a normal chest X-ray of a newborn baby. Okay, so the ribs are there. You won't see the anterior end of the rib because they are not still ossified. This will be intubated, so you can see the endotracheal tube here. Okay, so this is how a overall an X-ray looks like. We'll see what are the what are the pitfalls in it and how we correct it. Okay, plenty of time X-ray might look like this. Okay, here you can't see the the clavicles are projected way above the first rib. The ribs have become more horizontal. It is nothing but a more or less an oblique view, which is making the heart look larger, and the thymus covering the more or less the upper anterior and more 2/3 of the hemithorax. Okay, so this can be a normal chest X-ray, minded if your rotation and positioning is right. This how a sail sign looks like. Okay, so they look like a sail of a ship, and hence the name. So sometimes it may look like this. So don't start identifying, is it a collapsed lung or a pneumothorax surrounding it, or maybe a part of a pneumonia, or maybe developing lobar pneumonia. It could be just a sail sign of a thymus. Okay, thymus also can take such kind of a weird shape. See, this is a rotated X-ray. If you can see the area which is away from the plate, which will look more darker to you. So this hemithorax looks more darker to you. This hemithorax looks more brighter to you because it is near the plate. Hence, the right side is more above. So the one which was the thymus was supposed to hide behind the mediastinum or sort of merge with the mediastinum, it is showing as a separate entity. So you might see at some lump or some swelling or some mass in right hemithorax. This is nothing but a rotated X-ray where the thymus is getting exposed, with the exposure they never used to get. Ovular vascular markings are seen in central 2/3 only. Generally, they are not visualized in the peripheral 1/3 unless until there is some amount of bronchial edema is there. Air bronchogram appearance is very, very common, where you see the dense bronchi and surrounding air, so they look like a railroad to you. So overall, they are very commonly seen. If you want to see how a normal air bronchogram looks like, look behind the cardiac celularity. So in the left lower lobe behind the cardiac celularity, the air bronchogram, which looks like this is a typical of how it should look like, and they are normal. Please don't start identifying them left lower zone pneumonias. Thoracic vertebra should be clearly visualized. The spinal arcs are not fused in early neonatal period, so you will see the ribs are sort of separate from the vertebra. It is normal for vertebral bodies to have a central defect, so you might not see the central vertebral bodies. You might see their body which have a little translucency or radiolucency in the middle. It should not be mistaken for sagittal cleft or hemivertebra, which is clearly normal for this neonatal age. So typically see how an air bronchogram looks like. Okay, can you see this part, which is hiding behind the cardiac celularity? This is how a normal air bronchogram looks like. This part is completely normal. This is not a normal chest X-ray, but this is how an air bronchogram looks like. Okay, you can see on the right hand side, where you can see those kind of a tiny black markings. They run around, and there are some white margins surrounding it. This is air bronchogram, where the bronchus, the air in the bronchus becomes more visualized because of the thickened either bronchial wall or maybe the surrounding parenchyma being thick. Few again non-specific findings. Bilateral streaky pulmonary interstitial opacities, sometimes more than left side. These are the which are in the pericardiac region, which is again more or less a normal finding. Mid airspace opacification in right base. Mild airspace opacification in right base. Again, this is a perfectly normal finding. This is not a right lower lobe or lower zone pneumonia. Okay, don't start misinterpreting it. Interpret this X-ray in a light of clinical finding. How do we decide whether the baby has given a correct exposure or not? So examine vertebral column behind the heart. You should see the detailed spine and pedicle through the heart. You can see the pulmonary vessels in the peripheral lung. So that essentially means the 2/3, 1/3 type of division of vascular marking you should be able to see. So that makes the correct exposure. If the film is overexposed, you'll be able to see only the spine, but you will not be able to see the pulmonary vessels. The lung field may look oligamic to you, or maybe sort of darker and blacker. But by looking at X-ray or by looking at the film, there is no way to know that what kind of radiation or how much radiation exposure the baby has taken. So this is a kind of an overexposed X-ray. You can see the spine, you can see the disc. So you can see it behind the heart, but you will not be able to see any pulmonary vascular marking on either side. Even the hilum looks emptier to you. So this is an overexposed X-ray. Same underexposed X-ray, they look more like a whiteout to you. Sorry. So here you'll not be able to see the spine behind the cardiac celularity. They both merge with each other. Okay, the X-ray, the lung field start looking more or less white. The area which are not supposed to look white will start looking white to you. So this is an underexposed X-ray. How the rotation changes the view. Just concentrate on this white part. This is the area where the cardiac celerity will be there in a X-ray plate when they are exposed to X-ray beam. So if they were taken an AP X-ray, the heart is touching the spine, and if the rotation is well aligned, okay, you can see this much amount of area which is being occupied by the heart on a X-ray film. But if you rotate the patient towards the left side, okay, the heart moves toward left, and when we know the heart is situated towards more on the left side, that part looks more prominent, and that covers the more area on the X-ray plate. So here you will start diagnosing cardiomegaly unnecessarily, and exactly the opposite. Here you will see that the heart size may have shrunk, or you might see that the lungs may seem overexpanded to you, and simultaneously the right hemithorax might look more radiolucent, and you might start contemplating that this might be an overexpanded lung, or maybe the baby has developed a pneumothorax which has shifted the mediastinum, and the heart is shrink because of that. So it is nothing but a problem with the rotation, where the heart size changes according to the position of the baby in comparison to the well-aligned X-ray. So this is our rotation creates a trouble. Okay. So look at this heart. Okay, the left lung is hardly visualized. The right lung is more visualized. You can see the bronchovascular marking, and this part also getting exposed. Here, if you see, the heart is hardly visualized. And if you can trace the lung margin, you can see this lung margin going towards crossing the mediastinum. So this is not an overexpanded lung. It is just the rotated film, and you can see the obliquity of the ribs also. So ribs which are supposed to be taking a turn, here they are become more straight on the other side. Here they are taking a turn, they are more oblique, they are over each other. So this is how a rotated X-ray will create troubles with your diagnosis, whatever you are trying to see in the X-ray. This is more or less oblique, or we call it lordotic view, where the orientation of the ribs have changed. So going back to the sort of an X-ray, okay, where you see the ribs are coming from, no, from above downwards. So this is how the orientation of the ribs should be. Rather than here, the ribs seems to be going upwards. So this is nothing but a lordotic view, where the beam has come from the foot end of the baby, and it has exposed the baby from sort of bottom to top. So this is a lordotic view or oblique view, where you will see the orientation where ribs are wrong, and this is how you diagnose it. For the seeing the OG or NG tube placement, they are recognizable by the radio-opaque line in their wall. They should run distally in the midline and they generally loop within the stomach. You should be able to see the tip here, and tip should lie well below the left hemidiaphragm. So they should travel in the midline. They should gradually traverse towards the left side, cross the diaphragm, and should lie in the stomach bubble. This is how an OG tube looks like. Endotracheal tube, again, they have an opaque line in their wall, so that you should be able to see it. It should lie in the midline. Approximately, they should lie at approximately 2 centimeters above carina. That's an arbitrary number, especially mainly for the term babies. In the preterm babies, the number can be still less, but they should lie approximately 1 intervertebral disc space above carina. If you want to kind of measure it like this. So wherever the carina is there, approximately 1 intervertebral disc, or one vertebra above the carina, the tip should be placed. And tip should lie at a level of between C7 to T4, ideally between T1 and T1 and T3. Remember that tip moves with flexion extension of cervical spine. So it is very important that on what position you have taken the X-ray and what position you are nursing the baby. So if there is an extension, the tip will move up. If there's a flexion, the tip will move down. And if that's not the position where that's how you are nursing the baby, then you might you might misinterpret the position of the tip and kind of change the depth of the ET tube, whether even though it is not required at that time. Okay, can you see here? Okay, what's the right or wrong in this X-ray? Anyone? Kind of, you can put in the chat box. I'll keep asking in between. Okay, here the ET tube is here, completely above. Okay, this is again on the right side. There's a rotated X-ray also simultaneously. The tip is practically has gone way above. Okay, so this is not a right placement. Maybe the tip has not gone, reached the glottis even. Second thing, something like what you should not do while taking X-ray. Take care of the ECG lead placement. When you are placing an ECG lead, it is good idea to place both the limb leads on the shoulder, so they don't come in the placement of the PIC line also. They don't come in between the X-rays also. Simultaneously, we are using more or less an adult type of ECG wires, which has a clip type of end. So see to it that you remove them or you place them distally while taking X-ray. Because see this X-ray, okay, there are so many findings in the X-ray, but simultaneously we are not able to identify our area of interest, which is this, because the lid placement and because the phase change, okay, you might see the radiolucency, which may not be the true identification of any air leak inside. Okay, baby is intubated, pretty sick, has to have lead placement, has to ECG monitoring, has lines also placed in situ. Okay, but still because the lead placement, baby is going to have one more radiation exposure for no reason. Hyper expanded X-ray, how is it going to look like? The hyper expanded X-ray, the lungs are will look more black to you, but minded the film will not be overexposed. The entire heart will be seen above the diaphragm. Otherwise, the heart will be seen which is sitting on the diaphragm, and both the loops they curve like this beside the heart. So it is kind of heart which is sitting in between the two crura of the diaphragm. But here the heart will be sitting like a mountain of diaphragm. And diaphragm, the dome shape is being lost, and the diaphragm will look more and more flat to you. So this is how you identify that is not an overexposed film, but but an overexpanded lung field. How do you identify the lung volume, whether it is adequate or not? So identify the lung volume. Okay. Also see the line of the crura of both the diaphragm. The right dome of diaphragm will be placed a little higher up than the left one. Generally, a difference of approximately up to 1 rib space is being considered normal. When you are calculating lung volume, see to it that you start counting the lung volume from the first rib down. Okay, so if you are counting it, counted the first rib down, approximately in a well expanded lung field, you should be able to see the on the right side approximately 7 rib spaces to approximately 8 rib spaces on the left side. More than 9 rib spaces generally considered an overexpanded lung field. How do we calculate CT ratio? So here we take the right and left border of the heart, that's A, and the right and left border of the B. A divided by B will give you your CT ratio. So it is very easy to calculate, and see to it at that time the rotation, exposure, the other factor creating artifacts should be taken care of. So what's right and what's wrong in this X-ray? Okay, anyone can put it in the chat box. Let's move further. So let's see, what's right and what wrong in this X-ray. We'll try to identify by seeing the scheme of the X-ray. Okay, how do you read an X-ray when the X-ray being presented to you? So overall, these are the sort of markings when you should be seeing. It's more or less visible, more on the more for an adult. Just to show you or just to give you an outline, I have put an adult X-ray and shown it to you. You can take a snap of this slide if you want. Otherwise, this is available from free to download from internet. Okay, so what you should be able to see the trachea, be able to see both right and left main bronchus, should be able to see cardiac celerity. Okay, the pulmonary trunk, the aortic arch may not be visible because of they are obscured by the thymus, and try to see the bronchovascular marking. So overall, in the scheme of reading, start with appreciating technical issues. So see to it that whatever target area and view you have asked for, whether the X-ray of the same thing has been taken or not. Take care of the position, the rotation, exposure. If it is in chest X-ray, go to the lung parenchyma first. In lung parenchyma, try to identify the degree of inflation. See the air bronchogram. Try to identify collapses or consolidation. And at the end of the day, try to identify free air or maybe fluid inside the lung field. Once you are done with the parenchyma, try to look at the heart, try to identify the large vessels, try to look at the abdomen, liver, and other abdominal organs, whatever been exposed to. Later on, move to bones and joints. And lastly, whatever lines you can see inside. And take a heed in the mediastinum. In the mediastinum, you should be able to differentiate between the pneumomediastinum versus thymus, which is being pushed just because of the pneumomediastinum, or it is just visible just because of the rotation. So if you see a thymus which is just like a sail and surrounding lung parenchyma looks normal to you, it is a sail sign. But a pneumomediastinum will outline the thymus. So you will be able to see a dark black line which is surrounding the thymus. So that's nothing but a pneumomediastinum creating an impression of sail sign. So this is how you differentiate that it's a normal sail or a pneumomediastinum making the thymus become more visible. So when you are calculating lung volume, start counting the ribs from here. So what is right and what is wrong? Okay, so this is your first rib space, second rib space, third, fourth, fifth, sixth, seventh. Okay, you can see the dome of the diaphragm which is there, which is ending at the eighth rib, which is a little up below the eighth rib. So that is some amount of difference which is there between both the domes of the diaphragm. Cardiac celerity is there. This is the middle end of the clavicle. So see both the clavicular end, that will give you identification of the whether it is very well centralized or not. Try to see the disc between both the vertebra. They should be visible. They should be visible even with the cardiac celerity above it. When you are able to see spine so nicely, Simon is able to see the vascular markings also. This is how we can see that's a decent exposure of the lung. X-ray should not be taken like this. So few examples of this, what you should not do. This is an invertogram, a classic invertogram, which people used to do in favor, and still many pediatric surgeons do favor this kind of invertogram. Not in practice anymore, but this is what you should avoid. So whenever you are doing an X-ray, okay, plenty of time we see only the baby from above. Okay, plenty of time we forget to see the baby from below. Okay, so plenty of time these wires are hidden. Wires are hidden below the baby's bed, and these are what we are going what will become visible when you take an X-ray, and after taking X-ray you realize that, oh shit, this is what mistake I have done. So you should not take an X-ray like this. Try to identify the lines, try to take care of the lines, and accordingly take an X-ray so that they are not obscuring your area of interest. Whenever you are restaining the baby, see to it that you are not getting X-rayed, but the baby is. So your hand should not be observing the area of your interest. Again, a rotation like this, lead placement like this, okay, which will create an unnecessary impression of right lung developing pneumothorax, left lung getting collapsed, and simultaneously, okay, you start creating misdiagnosis and you want to see the right lung field, but the EC lead is obstructing everything. And here, see this, your catheter tip position, whatever you want to diagnose, those went haywire. When you are again putting a ECG leads, even though you remove the wires from the major of the area, okay, if you are taking a total 12 lead ECG, see to it that those leads also needs to be removed. While removing, see to it you don't create adhesive or skin injury, and simultaneously see to it that is not obstructing the lung field also. So whatever is obstructing the lung field, try to see that they are away from your area of interest. So read the ABCs. So overall, abdomen, bone, chest, and soft tissue. So we call it ABCS. So abdomen, bone, chest, and soft tissue. If you try to remember a mnemonic. For every chest film, read the abdominal portion, and you will read an abdominal film. Knowledge of anatomy is a key to right diagnosis. Airway should be visible on all normal chest film. Always review an old film to properly assess the new one. If you have if you have a serial X-rays done. In obstruction of lumen, there should be a proximal distension. Remember that. Try to find the effect of mass on the adjacent organ. And periosteum is generally not seen in neonatal X-rays. So these are the few rules when you are reading an X-ray. So the boring part of the theory is over. Okay, my preaching is over. So now we'll see the how the magic has been created on the X-rays. So shall we take this, ma'am, or shall we shall we answer the questions first?
Sir, as you wish, because the time
Is
factor is
sort
there.
of running
But
out, yes.
yes,
So,
you can take your own decision, sir.
yes, ma'am. So let's see that this is the my own personal collection of X-rays. Try to spend more time on this, and I hope you all will like the collection of it. So everyone, please unmute yourself. Ma'am, can participant unmute themselves?
They can write in chat box.
Okay. I'll keep the chat box on simultaneously.
Yes.
Yeah, so I can also read. So let the magic begin. So whatever X-ray you are seeing, okay, see that what is being shown in that X-ray. Okay, what is this? Please go. Please make fast. We don't want to do breakfast with each other. This is a skin fold. If you see that the way, okay, on any pneumothorax will not go beyond lung margin. You can see it is going in the abdomen also. This is more as a skin fold. Okay, what is this round cavity is? Okay, don't try to guess. When you take in X-ray in the incubator, when you are not open the canopy, mind it that canopies have this kind of fenestrations. Okay, this is not in the new incubator. They have small fenestration which are generally get exposed, but in the old incubator they used to have this round big circles or big gaps in the inner canopy for the circulation of air. So such kind of gaps in the canopy can look like some cavity in the X-ray. So minded that apart from the baby, there are other things also, okay, which can spoil your X-ray. Okay, what is this? Okay, this is X-ray of pneumomediastinum. Okay, this is so I'll give you 3 seconds for each diagnosis. Be fast in your typing. This is a selective ventilation of the right lung field. The selective lung field, you can see the ET tube going well beneath. It is mainly ventilated with the right main bronchus, but it has been overexpanded. Every lung is not normal. It's anybody's guess what the pathology is. You can see the left lung has got completely collapsed. Where the heart is, disappeared. Baby has acardia. Okay, so this is kind of nothing but a selective ventilation of the right lung field. What is this? PPHN is not an X-ray diagnosis. Okay, so please don't diagnose PPHN with this thing. So, one more clue. See the clavicles. This is a callus in the clavicle, old clavicular fracture which has created a callus there. Okay, so don't just get what you say focused on the lung field. I'm just trying to say, I'm not giving you any time to look at the or read the X-rays completely. Okay, but just trying to make you identify that yes, you should also see the peripheral areas also. This is overall, yes. Look, again, always try to diagnose or try to put findings in. Then when you are reading an X-ray, as finding not as a clinical or pathological diagnosis. Look at the bacterial pneumonia or mechanoaspiration syndrome. Okay, we really don't know. Okay, or okay, I've not given you any clinical details. So try to identify this is opacities. Okay, overall the lung looks hyperinflated. Okay, the cardiac salivity is pretty obscured. So this is more or less okay. It could be any lung pathology which is parenchymal pathology. Okay, and the ribs have become more straighter. There's more or less an oblique view. It could be. It can be anybody's debate, like a bacterial pneumonia or a viral pneumonia or it is a MS. It could be anything. Okay, but in absence of clinical details, try to read X-rays with findings, not with pathological or bacterial diagnosis. Okay, what is this? Any guesses? See the OG tube stuck above. Okay, so this is an X-ray with esophageal. Perfect. Wow. Wow, Dr. Manan. Great. Okay, this is the dye study of the same baby. Okay. This is after an surgery. Okay, so you can see the dye which is going completely down. Oops. Not able to move this. So let's move ahead. Okay, this is CDH. This is CDH. Okay, you can see the intestinal areas there. Okay, you can hardly see the stomach bubble. Okay, you can see the shift is there. You can see the tube which is going from the left to right. This is CDH. Wow, cool. You guys are definitely smarter than me. This is the dextrocardia or something different. Okay, this is partial situs inversus. Look again. Don't diagnose TTNB. Look, don't diagnose TTNB. The stomach is on right side. Okay, we presume the marker is right. It's not dextrocardia, so it is situs inversus, but it's partial because the dextrocardia is not associated with it. Okay, so try to diagnose this thing. Don't diagnose TTNB. TTNB is again a clinical diagnosis. More as a diagnosis of exclusion. Okay, this is a bad air leak. Okay, which is involving the mediastinum also, the hemithorax also. It is tracking the other side also. There is a pneumomediastinum and again a pneumothorax, a bad air leak. This is again another example of air leak, pneumomediastinum versus and pneumopericardium. Perfect, perfect. This is if anybody can identify, can you see this line and the difference in the lucency? If you see the clavicular border, more or less they are at the same level. Okay, the ribs are pretty well equally spaced. Yes. So this is a X of CLE which has pushed the mediastinum towards the right side. Okay, this is the example of reticular, how a reticular granular pattern looks like. Okay, which is observing the cardiac celerity. Plenty of time it is called the celerity sign also. Okay, this is can you see these linear shadows? Yes, this is PI. So PI generally divided between cystic and linear PI. Okay, so this is a linear PI, interstitial emphysema. Perfect. This is yes, more or less pneumopericardium and maybe some amount of because around thymus we can see a small this black line also, which is little different from the right lung field. So it could be simultaneously pneumomediastinum maybe coexisting with it. This is his cross-table supine X-ray. Perfect. This is free air in the abdomen, so a pneumoperitoneum. Perfect. What is this? See the left humerus. Yes. So see the peripheral areas. You can, when an X-ray is there and somebody tells you there is a finding and the lung fields are baffling you, okay, check out the peripheral area. That's the key here. This is perfect, perfect. Can you see these calcifications? Okay, which are as dense as the bones. Okay, it is overexposed film where the radial exposure is much high. You cannot see the vascular marking except those are behind the heart. Okay, so this is maybe they may be antenatal perforation or maybe the peritoneal calcification. So these are nothing but peritoneal calcification, which may take you as a surprise. So bioloops are definitely visible. They have to be visible. Okay, so this could be antenatal insult also, maybe meconium peritonitis, maybe meconium peritonitis leading to some peritoneal calcification. This is a simple dye study, okay, which is showing the dilatation of esophagus. So it could be reflux also, and this can be also seen very well when you after the surgery of tracheoesophageal fistula. So this is nothing but upper GI study. This is perfect. Yes, you can see the same thing in a post-staph repair also. And you can see some same kind of thing with the dilated stomach during the if you do an upper GI study for reflux also. This is yes, or rather an eventuation of diaphragm. Either way, whatever you call it, this requires surgical management. So either hiatus hernia, eventuation of diaphragm, maybe you can call it a CDH also. Okay, that's perfectly fine. But since the diaphragm border is clearly visible, okay, we don't call it CDH. Okay, because CDH only the rent in the diaphragm. Diaphragm doesn't move up. So diaphragmatic paralysis also can lead to like this. Okay, the hemidiaphragm paralysis could be hiatus hernia or could be eventuation of diaphragm also. Okay, here the emphasis on the shape of the heart, a kind of a boot-shaped heart. You can see this where the pulmonary area was there, the aortic arch and the pulmonary hub was there. Okay, those are missing. So yes, the most common diagnosis can be this thing. Again. Look, in a supine X-ray, there won't be never there will be a basal pneumothorax. Okay, so always the pneumothorax, the air will collect in the center and in the middle, the center and the above. Okay, so you'll always see the air which is here on either side. You will never see the basal areas. Okay, which are radiolucent. Okay, the air will never collect on the base, so you'll never see an X-ray like this. Okay, even if the base are getting radiolucent, then you'll always see the air tracking above, and you will see the lung collapse like this in the air tracking above because the air will collect in the center and in the middle. Sorry, center and the above. So this is the clue. The baby has BPD. Baby has BPD. Okay, the diagnosis is out. What else can you see? Can you see this cupping of ribs? So this is cupping and fraying of ribs. So this baby has bad osteopenia simultaneously. Only not the lung, his nutrition has also taken a beating. So okay, so when the babies who are a little older, especially premature babies are being ventilated or developing BPD, see to it that you see their bones also simultaneously. This will take you a surprise. Okay. Okay, no marks for guessing this thing. As I was telling you, if you see a basal area which is radiolucent and see a pneumothorax there, you'll always see an air tracking above. Okay, you'll always see an air tracking above, so you'll never see a completely nice lung field here and the radiolucent base. That kind of pneumothorax will never happen. Okay, so this is a typical X-ray. Again, an overexposed film giving and this is not an overexposed film. This is a problem with the contrast. So where you see the contrast, the difference between the phases. Okay, the one which is solid versus one has an air, one has a solid with one which sort of a fluidic phase. So you will see the stark difference between the phases. You see the stark difference between the lung parenchyma and the whatever vascular marking is there. You see the stark difference between the vascular and lung parenchyma and the bones. So when there is a stark difference is there is nothing but a problem with the contrast adjustment. It is more or less how the post-processing happened. You need to tell your radiographer that yes, I need to reduce the contrast, and many of this now the PAC system they do have adjustment for contrast. Samir, you can see here the sail sign, okay, which are adhering the ribs, and you'll see as if the boat is sailing. Again, a localized air leak could be a pneumomediastinum, could be a pneumothorax, which is the air is collected in the center and above because it's this in an AP X-ray. Okay. So here, can you tell me which catheter is what? Which one is this catheter? And which one is this catheter? Yes, it is curved UVC. Okay, yes, it is, must have gone in liver. Okay. But simultaneously, take a look at this. Okay, you will never see air collecting behind sternum. So this is again a pneumomediastinum. Yes, US is pretty much in position. Okay, so this is an air leak. Okay, ICD in C2 and whatever you are trying to place. Okay, it has gone into duodenum. but it has crossed the midline. So here, when such kind of, when you are placed an ICD and do an AP X-ray, but you always feel that no, my air is not getting drained, my air is not getting drained. You should always take a lateral X-ray, cross-table supine lateral X-ray to see where the tip of the ICD is. Okay, in here, okay, it looks my ICD placement is almost perfect. Okay, it is touching the spine or it is crossing, lateral crossing the midline. Apart from the depth of insertion, you might feel that no, my ICD placement is perfect. And see to it that I have placed two ICDs in this baby. One more ICD is going here, but still the drainage of air is not perfect. So what has gone wrong here? In lateral X-ray, I can identify that my air is collected here, okay, which is seen as a basal pneumothorax. But none of my ICDs has a tip where my area of interest is. So this ICD has a tip which is an upper mediastinum, which is pretty much behind the heart, not draining air. This one, it has got curved, and again the tip has come to the posterior mediastinum. So it has taken a curve here and it has gone back. But since it is a two-dimensional AP X-ray, it looks straighter to me. Whether it is a curved ICD, again the tip is here, which is not draining the air. So see to it whenever you are putting an ICD, you have to check the tip of an ICD, especially when it is not giving you a desired result. Take a cross-table lateral X-ray. Any guesses for this thing? Let's see this X-ray first. This is NEC, the tram track pneumatosis. This is portal venous gas. Okay, take a closer look. This portal venous gas. Okay, it will look like, it will look like a kind of bronchovascular marking only. So this is a kind of ominous sign. Baby is developing portal venous gas. There is hardly any chance to survive. Yes, there's a pneumatosis intestinalis. You can see the lot of tram tracking here. A lot of intramural gas. Okay, so this already I have already given the clue to this ARM. Yes. Now see the lines, where we want to place it and how they go. So mind it that you are not alone. I am not alone. So please don't get disheartened when your lines are not in place, because out of 3 lines you put, one will always go haywire. So that is the standard international criteria. They are going to be successful only 60% of times. Okay, so if your line goes haywire or not in place where you want it to be, please don't get disheartened. Don't feel alone. Okay, so this is an over enthusiastic me who has put the UVC also over inserted, that has gone into atrium. And my UAC has traveled from the descending aorta to arch of aorta to internal carotid. Wow. This I have inserted, okay, thinking of UVC misidentification of orifice, venous is arterial. Okay, so that has gone way much into the left subclavian artery. Okay, despite of all the measurement, all the efforts we do, when you want to look at transduodenal tube, we cannot. But sometimes the first resident who might be putting it for the first time will do it right. So this is a accidental, yes, at a D party. Okay, again a rotated X-ray. Okay, see to it that, okay, or more or less a good placement of UVC. We wanted to keep it just above the diaphragm in the supra-diaphragmatic portion of IVC. But again, rotated X-ray makes it looks like it is going somewhere else. Okay, a UVC which has bent down. Okay, this is not a low position UVC. This is a UVC which has a tip here. This bent down and taken a curve on its own. Okay, this is just to confuse you guys, that to identify which line is what. This is RT, feeding tube. This is UVC, and this is a low line UAC, because we all know that the venous line has a track which is straight above. The artery line goes a little down, takes a loop, and then it curves, then it moves ahead, and it is more closer to the ribs than any of the other of the catheters. Okay, here just try to see that what I was talking about, that the middle of the vertebral body may not be ossified, So you might see those a little bit of cleft. Okay, so those start identifying. Yes, Manan. So when UVC and UVC, the UVC has a curve which is straight above, and the UAC will go deep down, take a loop below, and then it moves forward. So yes. So your thinking is perfectly right. Okay, look at this UVC. UAC is more or less perfectly placed, but over enthusiastic me, which has put an UVC, okay, which has over inserted. It has taken loop in the right atrium, gone through PFO, it has gone into left atrium, and maybe is entered into a pulmonary vein. So okay, on a lighter note, we can say that I will be able to measure the pulmonary wedge pressure through this catheter. Look at this PIC line. Okay, this ladder flex. I don't know how did I manage to create this, but okay, there is a knot here. There's a true knot here. Okay, how do I create a true knot here? Okay, God, these are the diagnoses which we call it GOK. That is God only knows. So this is the GOK complication. Okay, this this is how the closer loop it looks like. The only thing which you need to take care of when you are trying to remove it, because if this is stuck or embedded in the venous wall, okay, the more you pull, the tighter the knot will be, and at that time the knot may not get pulled out of the venous line very easily, from the vein very easily. It might break from here. Okay, so see to it that when you are pulling it, see to it that you keep flushing it so that it doesn't get embedded in the venous wall. It stays free. Simultaneous flushing will keep this knot patent. Okay, not open. It won't get closed. Pull very, very gently. Keep flushing in between and gently, gently pull out and see because there is I know a doctor whose a court case is going on in whom the tip of the UVC got broken. It traveled, created a massive cardiac infarction. Nobody knew about the tip. We have nobody ensured it, and during the post-mortem, it was a sort of unexplained death. Post-mortem happened, and from the coronary, one of the fragment of the UVC was found, and the doctor is now facing a litigation for negligence. For when you remove the venous line, why it was not ensured that has come out completely. So see to it that they come out completely. Again, an over enthusiastic me putting a venous line which has gone from IVC to right atrium to again PFO, left atrium, and in a pulmonary vein. Only if your post-removal X-ray is required, only if you are not so sure that you are taken out completely. Okay, all this lines you are marking. The tip is nicely curved. Tip is nicely they are sort of beveled. So you'll see always they are little dome shaped. So tip will be always pointed, and the rest of the cannula will be straight like a cylinder. So if you don't see the tip, or you see the tip is frayed, okay, for any reason, okay, ये फटी सी tip दिख रही है, or you cannot identify where the tip is, okay, then take an X-ray. Otherwise, it's not needed. So when you remove any line, always check whether the tip has come or not. Okay, otherwise routine X-ray is not needed. Okay. Again, a UVC which has gone into one of the pelvic veins rather than going above, it has gone down. Okay, and a nicely placed PIC line simultaneously. Okay, a UVC which has curved and entered into one of the hepatic veins. Okay, and little low lying UAC. Okay, so there I'll end. I'm done with the presentation. Regarding the adjustment of lines, look, it is always good when you're trying to put it. It is always good to over insert these lines, because as soon as you put the dressing and as soon as you're done with the procedures, okay, you are inviting the environment to colonize the part which is outside. So you cannot insert it, but you can definitely withdraw it. So kind of take it as a cutoff. Say for example, umbilical line, you have fixed it at 8. So those 8 centimeter are in the sterile area. From 8 onwards, it's in a contaminated area. So 8 onwards, the umbilical line is contaminated. So you cannot put the contaminated area or contaminated line in the sterile area, but always you can put the sterile area in contaminated area. You can always, you have an option to withdraw the line, but not the insert the line.
रिक्शा में 10 मिनट पे चाहिए.
Okay, Sam, I'm done with the presentation. If there are any questions, please put it in the chat box and I'll try to answer with best of my capacity. I'm glad to have my senior and one of the very good friend, Dr. Rajesh sir is here. We are alumnus to the same college. So whatever my blunders I have shown with lines going haywire, okay, you may not be surprised. So if there are any questions, please shoot. If any of the points you want me to highlight or run through again, okay, regarding the X-ray exposure, regarding the technique. KVP signifies not the penetrance, but the dose. Penetrance is decided by the overall density of the tissue. Look, you cannot count the rib anteriorly because the anterior costochondral junction is not ossified only. So you'll not be able to see ribs anteriorly at all. So we always count the rib posteriorly from the spinous end. So where we get attached to vertebra, we only can count those posterior ends only. So you count that, check, identify the first rib. The below the first rib is first rib space. So start counting rib space from first rib below. So KVP signifies not the penetrance, it signifies the dose. So kind of radiation what you are imparting. Kind of manner. It's like there is no dose which is or no exposure which is safe. So try to keep it at minimum. Okay. So always judge a risk benefit ratio. How to get the X-ray technique for correct exposure? I have given you a table. Okay. So those milliamperes decided by the whatever machine you have, and simultaneously how much exposure you want to give, that you need to that adjustment you have on the machine. So I have given you a table. If you want, shall I go to that table? How to compare any distended loops? Okay, overall, whenever you call the loop as distended, that essentially means that if the loop is more dilated, then one vertebra. So one vertebra, essentially vertebra and the disc both. So if you take the total, so the width of one vertebra and one disc, if the loop is dilated more than that, okay, so that's when you call a distended loop, and that should sort of trigger your sixth sense that I may be looking at a developing NEC. Thymus and mediastinal mass, how to differentiate? Frankly, you cannot. Okay, because thymus itself is a mediastinal mass. And by looking at it, unless until you see it adhering to the ribs and creating a sail sign, there is no other way to know whether it is thymus or we are looking at a mediastinal tumor or any other dilatation or maybe a diverticulum there. So there is no other way to identify Soumya. So I think what you are asking, Soumya, is how to identify thymus and a thymus which is just seen just because of pneumomediastinum. If that's your question, then yes, when there is a pneumomediastinum, the thymus will be outlined by a rim of air. So when you see a thymus which is on a backdrop of normal lung parenchyma, how to abdominal X-ray? So again, look at the, when you see an abdominal X-ray, look at the whatever you want to see in abdomen first. So look at the organs. So try to see the liver, try to see the gastric bubble, try to see the spleen if it's visible. Generally, it is obscured by the gastric bubble, so it's not visible. Try to see the abdominal loop and try the distribution of abdominal loop. So once you've identified, yes, I can see these organs, then try to the characteristics of their organs. Liver, whether they look huge to you, normal size to you, whether they are looking an umbrella shaped like that, because asplenia babies will have an umbrella shaped liver. So whether it is like that, same with stomach bubble, whether right or left, it is over distended. Generally, the stomach bubble, unless it is over distended, normal stomach bubble will not cross a midline. Then the loops, whether they are distended, I just discussed how do you identify distended loop.